Hello and welcome to the tail end of the hip lecture. My apologies that we weren't able to finish this during lecture, so I just wanted to post a video with the last few slides, starting with I'm going to kind of take a step back and discuss GLAD a little bit. I know we discussed it in class, but just to kind of give you a little bit of overlap. And so GLAD is this program that it stands for Good Life with Osteoarthritis in Denmark, but it does run all over the world, especially here in Canada is actually a big hotspot for it. And it's a community-based exercise and education program for people with knee and hip arthritis. So, in essence, it is a program that includes uh, or that follows the guidelines that we just discussed above the ACR guidelines and the ORC guidelines that suggest that we should be utilizing education, exercise, and self-management strategies for all individuals with hip and knee arthritis. Okay. And so this program, individuals with identified hip and knee arthritis, usually through X-ray or some sort of assessment. I believe they have to be to be included in the database for GLAD, I think they have to have X-ray diagnosis, but I could be wrong about that. I'm not actually certified in GLAD. But in essence, these individuals come in, they go through some exercise every day. I think it's a 6 or 8 week program. They get an education seminar from an expert, whether it's a physiotherapist, a chiropractor, a physician, and then they learn all sorts of self-management strategies to do at home. So it's a fantastic program. I've got the link down below if you're curious to take it. I think there is a way for kinesiologists to take it once you've graduated, but you can't take it as a student yet. And so some other that's kind of the mainstay. Like the vast majority of individuals will go through some sort of exercise program like GLAD. You can also go through sort of a stepwise progress of other types of therapies, corticosteroids, visco supplementation injections. There's certain types of braces that can be helpful, probably more so for the knee than the hip. For the hip, you have to use like a hip spica, which is a bit of a nightmare. You can see there's a picture of a hip spica on the right side of the slide here, or you can go towards a hip arthroplasty or replacement, which we discussed during lecture. Another reason for why someone would need a hip replacement is a fracture, right? And so you can get fractures in the femur. It can be in the shaft, it can be in the head, it can be in the neck. The most common place to have a fracture is the femoral neck, which you can see demonstrated in this X-ray of this right hip here. The fracture, if you can see my cursor, is right along the femoral neck here. Okay. This can be common with falls in elderly individuals, generally with osteoporosis or osteopenia. And the big risk of this, especially in young children, because children can get this too, is you can actually sever or disrupt the blood supply that feeds into the femoral neck and then supplies the head. And so if you fracture the femur at this point, you can actually cause necrosis of the head of the femur that can die, become necrotic, and cause all sorts of issues. So that's not a good thing. That's something you always monitor if a child has a femoral neck fracture. There are two different surgical options, which we discussed in class, and I'll briefly touch on them again. But you've got the hemiarthroplasty and the total hip arthroplasty, or the THA. And so these are a very common surgery. Mostly what I see is due to severe osteoarthritis, and they can honestly be life-changing. Like people's functional outcomes are much better after they have a total hip arthroplasty. And so for you as sort of a rehab specialist, as a kinesiologist, what you really care about is the post-surgical care, which needs to begin immediately. As soon as the person gets their new hip, then they need to begin their rehab. Another aspect of it, which we're going to talk about later in this course, is something called prehab. Hopefully, you've heard of prehab or prehabilitation. In sort of one sentence, the more you do before your surgery, the better your outcomes after, right? You strengthen all the tissues, You learn the exercises that you're going to need for afterwards. You groove some motor patterns. There's lots of benefits to it, which we'll discuss. But prehab can be really important. And with anyone who has is getting a total hip arthroplasty for, um, let's say, osteoarthritis, generally they know well in advance, so you can initiate that prehab scenario. So here's the two described. We discussed this in detail in lecture, but you've got the hemiarthroplasty, which they essentially replace one side of the joint. So they typically replace just the proximal femoral head, not the acetabulum. Whereas the total hip arthroplasty, they replace the head of the femur, but they also replace the acetabulum. And so one of the big benefits to this is you can actually make a perfectly congruent fit between the femoral head and the acetabulum. When you do a hemiarthroplasty, then um, the big downside is you can't control what the acetabulum side of the joint looks like, right? So you're trying to match it with a prosthetic, which doesn't always go well. So, the vast majority, I don't know the exact numbers, but the vast majority of replacements are going to be the total hip arthroplasty because both sides are typically affected by osteoarthritis. But if you have a young individual and they want to preserve as much of the native anatomy and bone structure as they can, a hemiarthroplasty might be indicated. This can especially be important in case they need to go for a second surgery or a third surgery later on in life. So as you can see in the right side here, for a total hip arthroplasty or hip replacement, both sides of the joint are generally very affected. And so replacing both sides just gives you a clean slate and gives the person the best functional outcomes afterwards. Worst pains usually the first day, and actually this is kind of a day surgery now. They get patients up, walking and moving, sometimes out the door within a day. COVID really accelerated those the hospital stays, and so nowadays people are up and moving as soon as possible. We want them to return to their ADLs ASAP, generally within 6 weeks, given proper physiotherapy and extended care. And there are multiple approaches that are possible. I'm probably going to leave that discussion for one of the case reports. But you can do a posterior, a direct anterior, or posterior lateral direction. There's different advantages. You can go along different fascial lines and not cut through so much muscle, or you can cut longitudinally through a muscle instead of horizontally across it. So there's a bunch of different reasons why a surgeon would pick one over the other, but I'll leave that for the case reports. And then again, hospital stays are generally pretty short, 1 to 5 days, depending on the severity of any adverse outcomes. And it's important to know that an earlier start to therapy results in better outcomes and faster return to activities of daily living. Okay. If you know someone getting a hip replacement, drive it into their head. You need to start rehab immediately after. You need to start early mobilization to make sure that you get full range of motion at the end. You need to start to load the leg because you want to build up the strength between the bone and prosthetic interface so that there's a strong formation of healing that happens there. And you want to start your physical therapy very early as well. Okay. There's all sorts of rehab protocol. Here's a great one from Sunnybrook. I've used this one a number of times with patients. Uh, if we have time during lecture, I will open this up and we can go through it just to see what it looks like. But it often gives a lot of recommendations on lifestyle factors, rehab, and all of the like. So here's some rehab for the hip, not specific to osteoarthritis, but a lot of them are included in protocol like the GLAD. Please remember when you're doing your case reports, if you do come across, and you should look for a protocol like GLAD because there's tons out there, and you should utilize it to your advantage when you're making your home exercise programs and your clinical sheets with that you're going to submit for the presentation because there's tons of protocol. There's no reason to reinvent the wheel. So here's some great examples of some exercises. We've got fire hydrants, which you can see here. We've got heel slides. I don't really see them anywhere here. Oh, there's some heel slides. You need to stretch the piriformis for the hip. You can bring the leg up and in, up and out. Here's another piriformis stretch. 90-90s are one of my favorites. These are all sort of mobility stretches, and so I like to I like to, and I've said this in the past, so I'm echoing myself, but I like to split things up between mobility and stability. So mobility is more that stretching and being able to move within your full range of motion, and then stability is being able to stabilize and the strength of the muscles. And so here's some sort of strengthening exercises that you could do as well, right? You could do lots of banded work. There's hip flexions, extensions, abductions. Clamshells are a great exercise. Um, Clamshells are here. You've got monster walks side to side. You've got any sort of variation of glute bridges. I've put all these videos on throughout your lab, so I'm not going to repeat them right now. And then you can get a little bit more advanced for some strength. So things like squats, star excursions are a great exercise. We'll go over this with the ankle as well. There's some airplanes there. You've got Bulgarian split squats, inline lunge. This is called the Copenhagen hip adduction exercise. Very, very challenging. Anyone who has a groin strain or an adductor strain, you need to start this very, very gently. Most of the time, I will start, if you're going to start to do any sort of activity, it's usually in this position, squeezing a ball together to activate the adductors. This is more end stage, and typically I would start them on their knee because it's a shorter moment arm and then move out to the ankle. But that's one of my favorite exercises. Okay, let's talk about some outcome measures. So we've got the WOMAC, the lefts, and I just want you to know that the lefts is non-specific to the hip. Okay, and in fact, so is the WOMAC. So the WOMAC is specific to, I believe, osteoarthritis. It's an arthritis index. The lefts is so WOMAC stands for Western Ontario McMaster Arthritis Index. The left stands for lower extremity functional scale. And this one, honestly, you can apply to any sort of musculoskeletal injuries. It's highly diverse. It's utilized in diverse situations. I use it all the time. For the lower leg, this is kind of my mainstay in the clinical sense. So let's talk about these outcome measures. Starting with the WOMAC, you've got, as I said, it's the Western Ontario and McMaster Arthritis Index. Bit of a mouthful. That's why we call it the WOMAC. It is a self-administered questionnaire about the hip and the knee, specifically for arthritis. And so it assesses for functionality in activities of daily living, mobility, gait, general health, and quality of life, and has been validated in many, many countries. So you could find basically any language you would want the WOMAC in because it is such a utilized outcome measure. And it's kind of cool that it was developed here in Ontario. It is also applied across other types of rheumatic conditions. So rheumatoid arthritis you've likely heard of, but there's various types of rheumatoid arthritis. There's juvenile rheumatoid arthritis. There's other conditions where you are positive for rheumatoid factor in your blood when they test for it. So technically those are rheumatic conditions. And it's nice because you can verbally administer it and you can also do it in writing. The reason this is nice is because sometimes you're dealing with, say, elderly patients. Maybe they can't read so well, or maybe they can't hear so well. So you could decide whether you want to deliver it verbally or in writing, or you could do it over the phone even if you wanted to. So I want you to know the different subscales. There are three subscales, 24 questions in total. We're looking at assessing their level of pain, their level of stiffness, and their level of physical functioning. Okay. And if you have arthritis, or if you know anybody with arthritis, you can understand that these are three very important scales to understand and interpret. You want to know what their discomfort level is, are they able to move, what's their stiffness, and then physical functioning in their everyday life. And so the scoring goes from 0 to 4, from none to extreme. And the higher the score at the end of the day, the worse the pain, stiffness, and functional limitations. So let's say you go through this 24 item questionnaire, they've got a very high score. Well, you're probably going to want to look back and see where are they having the most difficulty? Is it mostly stiffness? Are they going to have a really high stiffness score? So, like, say, 7 or an 8. Is it bad physical functioning? There's 17 items there. So, if they have a really high score there, we're going to start to focus our attention on their physical functioning and, let's say, like cleaning themselves or bathing or grocery shopping, whatever it may be. Or are they simply worried about pain? Because if that's the case, if pain is the big thing that's limiting them from doing things, there's certain things we can do to reduce pain in order for them to move better and in order for them to actually engage in the exercise that they need to make themselves better. Okay. So there's the WOMAC there. You've got your pain, stiffness, and functional score, or sorry, physical functioning. And so the individual just goes through and you say, rate your pain when walking, climbing stairs, sleeping, da 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 da. So you can easily do this over the phone if you needed to. Moving on to the lefts. The lefts is not specific to arthritis. It is only associated with anything in the lower extremity. So it's a lower extremity functional scale. Okay. It's a patient-related outcome measure for lower extremity functionality. Um, and you can use this for the hip, the knee, the ankle, the shin, the toe, whatever you want, right? And so this one, you'll recognize this scoring system. We've seen this on a number of other ones, but it's from 1 to 5, from extreme difficulty to no difficulty for a maximum of 80. And so it's a functional score. So higher scores indicate higher functioning. And apologies, I didn't give you a copy of it in the lecture slides, but I will try to give you a copy um, on Canvas. And so some of the strengths of the lefts are that it can be used for any injury in the lower leg. Like I love that. I love the your ability to utilize it in multiple scenarios. It's really simple to understand. It's really simple to administer, and it correlates very heavily to activities of daily living. It's shown to be very valid, so it does tell you when a person has high or low functioning when compared to a gold standard form called the SF-36. Um, it's got very high test retest reliability, meaning if you give the same test to the person, you're going to get the same score over and over again. And probably the biggest weakness is that it just reflects Western culture. It was made in North America, and so a lot of the things can be reflective of our culture, and it is a little bit insensitive to other cultures. Not insensitive, but it just doesn't give credence to other things that are important to other cultures. Okay. And the minimum clinically significant difference, uh, or minimally clinically important difference, which is just another way of saying that, is 9 points on this. So you need to score a difference of 9 points if you're giving this over and over to somebody to show that it's gotten better or it's gotten worse. Okay. Thank you for taking the time to listen to this. Sorry, the image must have been scrubbed from this before I did the lecture today. So I will see you in lecture. Have a great day.